Now, inability can adversely affect virtually any part of the body, but we're going to focus in on certain systems. And what I'm going to do now is run through briefly the systems we're going to look at in this video that can be adversely affected by immobility. So, hazards of immobility on the various body systems. A systemic approach to this. And the first we're going to think about are adverse effects on the cardiovascular system. So how immobility can adversely affect the cardiovascular system. One problem is you can get clots of blood forming in the deep veins of the leg and the lower part of the pelvis. Another problem is you can get small emboli in the lungs, well, small and sometimes large emboli in the lungs, very often breaking off these clots in the legs. So deep vein thrombosis, pulmonary embolism. Postural hypertension means you feel dizzy when you sit up, so the patients can become posturally hypertensive. And patients that are nursed lying flat can have an increased cardiac workload initially. So various complications there that we're going to look at affecting the cardiovascular system. There's also adverse effects on the respiratory system when a patient is immobilised. And the one we're going to consider is hypostatic pneumonia. Pneumonia is infection of the tissue of the lung, and this can occur as a result of hypo-low stasis movement. So immobility can predispose an individual to pneumonia. There's adverse effects, as we have already partly discussed, on the musculoskeletal system, the muscles and the bones. For example, osteoporosis is loss of bone mass. Muscle wasting and joint stiffness. Muscle wasting we've partly discussed, and the joints can stiffen up, making movement more difficult and less likely to occur. So adverse effects on the cardiovascular, respiratory, musculoskeletal, and adverse effects on the urinary system. Problems include formation of calculi in the urinary system, both in the ureters, the bladder, and possibly affecting the urethra as well. Retention of urine, difficulty getting rid of the urine from the bladder, difficulty in passing the urine. Incontinence, inability to control the flow of urine. And infection in the urinary system. So several problems there which can affect the urinary system. Immobility causes adverse effects on the gastrointestinal system. The patient might not feel very hungry, not eat properly, although there again they may, depends on the patient. But very often constipation is a problem here. Metabolic changes can occur in the body, and we've already mentioned one of these, lowered metabolism, lowered basal metabolic rate. And of course, if someone's left lying around in bed, immobilised for long periods of time, there can be psychological, sociological, and even potentially psychiatric complications. Now, of course, one of the classic effects of immobility, when a patient is left sitting in a chair or in bed, the problem of pressure sore formation. A big potential problem that nurses spend a lot of time preventing. But we're not going to look at that in this talk because it's such a big subject. We'll deal with that separately. Pressure sores, of course, reduced integrity of the skin, the integumental system, and ulceration can develop. And of course, all of these effects of immobility can result in care deficits that the patient is unable to care for themselves properly. So hazards of immobility on body systems. Immobility can adversely affect the cardiovascular, respiratory, musculoskeletal, urinary, gastrointestinal. There can be metabolic changes, psychosocial, stroke, psychiatric changes, and there can be pressure sores, and the patient will have care deficits. So all of these things can occur, all these problems can occur as a result of immobility. This is why it's important for nurses to try and minimise the amount of time the patient's immobile for whenever possible. Let's carry on now and look at these systems in more detail, and we'll start off with the effects of immobility on the cardiovascular system. So effects of immobility now, looking specially at the cardiovascular system. System 1, cardiovascular. And the first problem we're going to consider is the possibility of a deep venous thrombosis. Deep vein thrombosis. Usually abbreviated, of course, to DVT. Now let's start off by simply defining these terms. The deep veins refer to the deep veins in the legs and sometimes in the lower part of the pelvis. Now in the legs there's two venous systems. There's the superficial venous system, which are the veins just under the skin, which you can see very often quite clearly. And there's the deep veins, there's another venous system in the leg, the deep veins, which lie in the muscles, in between the muscles, deep inside the leg. And the problems with thrombosis occurring in immobility usually relates to the deep veins. Thrombosis, the term thrombosis, essentially means a blood clot. So the problem of deep venous thrombosis, or DVTs, is the possibility of blood clots forming inside the leg. Now, if there's a blood clot inside the deep veins of the leg, it's usually very painful, and that leg usually swells up a bit. In fact, can swell up very profoundly, in fact, because the blood can't get away, so it swells up as the leg tends to fill up with blood. So that's the term we're looking at, blood clots in the deep veins of the leg, DVT. Let's think about why this occurs. Blood flow from the limbs back to the heart is aided by the pumping of the calf muscle and the sucking action of the inferior vena cava produced by breathing. So let's think about that in terms of normal physiology. So if we look at me, for example, the reason there's blood down in my feet now, and the reason the blood is able to get back is because I'm moving my legs a little bit. And the key movement actually is moving the calf so it's tight, moving the calf tight, bringing the foot up, dorsiflexing the foot. When you do that, when you move your foot up like that sort of movement, then the calf muscle tightens up. That squeezes the veins in and the blood actually goes scooting back up the leg when you do that. It's quite a profound effect. In fact, it's such a profound effect that it's called the calf pump. It's almost like your calf is working as kind of a heart, really, in your legs almost. The blood comes scooting back up when you do that. So when your patients are in bed, tell them to keep moving their ankles, bringing the foot right up as far as it'll go. And that'll keep the circulation going back up. So that's one thing. The blood is pumped back to the heart to be used again by the calf pump. The other thing is, during breathing, you set up negative pressures in the thorax. So when you breathe in, ribs goes up and out, diaphragm goes down. That increases the volume of the chest. If you increase the volume of the chest, you decrease the pressure. That's why air is sucked into the lungs. But as well as air being sucked into the lungs, because the pressure is decreased, blood is also sucked back up from the big veins in the lower part of the body, back into the thorax, and of course your heart is in your thorax. So the blood returns to the heart because of these negative pressures. So movement of adjacent muscles facilitates venous return. Respiratory effort facilitates venous return. And as long as the blood keeps flowing and the flow of blood is not interrupted, then the blood shouldn't clot. It's when the circulation becomes slow and sluggish due to immobility that clotting becomes more likely. So that's the way that blood normally gets back to the heart. And if that's slowed down for whatever reason, then blood clots become more likely. That's why DVT is a complication of immobility. So blood flow from the limbs back to the heart is aided by the pumping of the calf muscle Just to underline that's the important part, pumping of the calf muscle, and of course the other muscles of the leg. And the sucking action in the inferior vena cava produced by breathing. So when someone is inactive in bed, the limbs are not moving as they are when you're walking around, and because there's not much exercise, respirations are shallow. So because the limbs are not moving, the muscles are not contracting, therefore the blood is not being pumped back to the heart. And because breathing is shallow, relatively shallow, it means the negative pressures set up during respiration are fairly low. Therefore the blood is not sucked back into the thoracic cavity as efficiently as it would be in a person who is mobile. Therefore venous circulation becomes sluggish, and when the blood flow is sluggish, blood clots are more likely to occur. And indeed, when the patient's lying in bed, the problem is complicated even more. Because you get compression of the veins in the legs between the bed and the bones. So when someone's lying in bed, if this is the leg here, very good foot there, but the bones in the leg are pressing on the muscles underneath. Pressing on this muscle underneath by virtue of the weight of them. And of course we've said that the deep veins go through the muscles, therefore the veins are compressed in the muscles by the weight of the bones. So compression of the veins in the legs between the bed and the bones slows down blood flow even more. And as well as slowing down blood flow, there's a possibility that it might damage the lining of the veins. And if the linings of the veins are damaged, then that means that the epithelium, which normally facilitates a very nice smooth blood flow over the surface of the veins, can be damaged. And that means that the blood flow, instead of being laminar and linear like this, just going past nice and quickly in straight lines, the blood can become turbulent, because if there's an interruption in the mucosa, in the lining of the vein, it can become turbulent. And you get turbulent blood flow. And when you get turbulent blood flow, you're more likely to get clotting. So you've got the slowing down of the blood flow, you've got the compressing of the veins, and you've got the possibility, due to the compression, of damage to the epithelium in the veins, causing turbulent blood flow. So you've got slow blood flow, which may be turbulent, therefore deep vein thrombosis is much more likely to occur. So just go over that again. Compression of the veins in the leg between the bed and bones slows the blood flow. Slow blood flow, remember, is more likely to clot. May damage the lining, which can cause turbulent blood flow and lead to the aggregation of platelets. Aggregation means that platelets can collect together on the damaged surface of the blood vessel. And when the platelets start sticking together, a clot can then start to form. Now, why is it we're so worried about blood clots forming in the leg? Well, it's a nasty, painful condition and further interferes with the patient's mobility. But as well as that, there's another reason why we're particularly worried about it. Now, if part of the blood clot floats off from a vein in the leg, it will come up through the veins in the leg into the larger veins, and then eventually it will end up in the inferior vena cava, which drains the bottom part of the body. No problem there. Well, I'm saying there's no problem yet, because if it forms in a smaller vein in the leg, as it comes up, the veins in the leg are getting bigger, and the clot can flow easily through these bigger veins. Then the inferior vena cava drains into the right atrium, and the clot can get into the right atrium there because, again, the right atrium is big. It can get through the valve, through the tricuspid valve into the right ventricle, but then it's pumped out into the pulmonary artery. And the pulmonary artery soon divides into two, the right and left pulmonary artery, one going to each lung. And very soon they start to subdivide into smaller arteries. So can you see now that the passage for the blood is starting to get smaller? So that means there'll come a point where a clot of a given size lodges in the arterial system. And that means it will occlude part of the circulation to the lung. And that's the next complication we're going to look at, pulmonary embolism. But let's finish off the DVT part first. Let's look at this diagram. We'll start at the bottom here. Suppose a blood clot forms in the calf here. And these clots tend to elongate and sometimes actually dam back into other veins. So this is a DVT. It's going to occlude venous drainage. Therefore, this limb will tend to swell up and be painful. And very often it will look inflamed. Swollen, painful, inflamed limb due to the deep venous thrombosis. So, for example, this could occur in the posterior or the anterior tibial veins, down in the lower part of the leg. And if part of this blood clot breaks off, it'll go higher up into the back of the knee here, into the popliteal vein. Or there again, of course, the blood clot could form higher up. It could form in the popliteal or higher up, but it depends where it forms. The blood flow then goes back into the femoral vein, higher up in the top part of the leg. And again, here the vessels are getting wider. So if a blood clot is on the move, of course a blood clot on the move is now called an embolism, then that will be able to move quite freely through this part of the venous system back up towards the iliac veins in the pelvis and towards the vena cava. And of course, again, the veins are getting bigger here, so there's no problem. And eventually, as it comes to about this level here, it becomes the vena cava. This is the vena cava here, the inferior vena cava. And that, of course, drains back into the right side, into the right atrium of the heart. And as we'll see later, from there it goes into the pulmonary artery and can cause problems. So there we have the deep veins of the body. A DVT can occur anywhere really, not normally in the iliac veins, but it can in theory occur in the iliac veins. Normally in the deep veins of the leg. Bits of it can break away as a result and form emboli, which can go back to the heart. So the deep veins of the body illustrated there. Let's think now about the signs and symptoms of a deep vein thrombosis. How would you recognise one should it occur? Hopefully it won't occur. Hopefully we're going to prevent it. But should it occur? Signs and symptoms. Well, it is a painful condition. Pain round about the clot and in the area of the leg below the clot. In the area of leg distal to the clot, because that's going to have its venous drainage inhibited. As we've said, of course, swelling of the affected limb. Now, there's a chap called John Homan, who was an American surgeon. In 1877, he identified something which has become called Homan's sign. And Homan's sign is pain in the calf when you dorsiflex the foot. So let me just show you what I mean by this term dorsiflexion. Now, when you move a foot down that way, that's called plantiflexion. And when you move it up, it's called dorsiflexion. So when you get a foot and move it up like that, then that is going to have the effect of tightening the calf muscles. And that's what Homan's sign is. When you push the foot up like that, you get extreme pain in the calf. Now, what I want to tell you now is why I've told you this. So Homan's sign in a DVT, when you push the foot up, when you dorsiflex the foot, you get an acute pain in the calf. And as I said, the reason that I've told you this is so you do not do it. Do not do this if you suspect a DVT. I'm going to say that again. Do not do this if you suspect a DVT. Firstly, it will be very painful to the patient, and as well as that, when you do it, bits of the clot can break off and go into the circulation and form pulmonary emboli. So if you suspect a DVT, approach a suitable medical person who can diagnose it, hopefully without trying Hohmann's sign himself. So it's very well known in nursing and medicine that positive Hohmann's sign is an indication of DVT, but don't do it because it's a dangerous thing to try. So going back to the signs and symptoms, raised temperature and increased pulse will develop. Raised temperature because as the clot starts to be broken down by the body's phagocytic defence systems, cell contents will be released into the blood. These will affect the hypothalamus, they're pyrogens, and can cause a temperature. Any dead tissue in the body can lead to a pyrexia. Doesn't necessarily mean there's an infection. So signs and symptoms of acute pain, swelling, positive Hohmann's sign, please don't do it. Raised temperature, increased pulse. Let's now think about risk factors in a deep venous thrombosis. Now the reason I'm telling you about risk factors is so that you will know about them, therefore you can eliminate them if possible or minimise them if it's not possible to eliminate them. So risk factors contributing towards development of a deep venous thrombosis. Well, clearly immobility is a risk factor. So you can minimise immobility either of the whole person or of just that part of the body. And ladies on oral contraception, the oral contraceptive pill in women is a risk factor. Not too big a one, but it is a slight increase in incidence of DVT. Smoking cigarettes is a risk factor. Don't let your patients smoke while they're in bed. Apart from anything else, they'll cause fires. Another risk factor is if an individual has had DVTs in the past, or if first-order relatives have had DVTs, because while these things aren't genetic, there probably is a tendency to run in families, and certainly some individuals seem prone to them for genetic reasons. They're particularly likely to occur if there's fractures of the pelvis or fractures of the leg. In pregnancy, because of the occlusion of the, or partial occlusion of the venous return in the pelvis. And in patients who are hypercoagulable for whatever reason. This means in patients in whom the blood is more likely to clot. For example, in polycythemia, where there's an increased number of red blood cells, blood clotting is more likely. So some risk factors there, be aware of them, eliminate them where possible. Let's get on to the important bit for us, the prevention of DVTs. How are we going to prevent DVTs by good nursing practice? The key thing, really, I think here, is regular leg exercises. At least, absolutely at least, 1 hourly. And if the patient is unable to move their feet and their ankles and their legs, you do it for them. So every 15 minutes or ideally every 5-10 minutes, the patient would voluntarily move their legs, flex their ankles, dorsiflex their feet, tighten the muscles up, carry out whatever leg movements they're able to carry out in their particular position, depending on the cause of their immobility. So remind the patient to keep their ankles moving all the time, so the patients are waggling their feet in bed every few minutes, hopefully. Remind your patients to do that. If they can't do that, then you need to passively exercise the legs. That means you pick the legs up, you move the knees, you move the hips, you move the ankles, you put the joints through a range of movements once every hour in patients who are unable to move themselves. For example, patients that are comatose or patients that are too confused to move themselves. So active exercise when the patient moves the legs for themselves, passive exercise when you do it for them if they're unable to move actively. Keep the legs moving, keep that'll tighten the muscles up and get the blood going back and reduce venous stasis and hopefully prevent thrombosis occurring. Patients should avoid lying in bed with their legs crossed, because when the legs are crossed, the muscle of one leg, the leg that's on top, will be pressed between the bone in the leg on top and the bone on the leg on the bottom. So it increases compression of muscles if the legs are crossed. Nor should patients have pillows underneath their calves, because anything which is pressing into the calf muscle can potentially cause turbulence in blood flow, and as we've said, that makes thrombosis more likely. Patients should be encouraged to carry out deep breathing exercises. Deep breathing will cause increased negative pressures in the thorax, which will suck the blood back up into the thorax, back to the heart, therefore improve venous circulation, therefore reduce venous stasis. Regular changes of position will also cause skeletal muscle movement and increase venous return. Sometimes you can use aids like a bed cradle to remove the weight of the bedclothes from the calves, because if the muscles being compressed by the weight of bedclothes as well as the weight of the leg, especially if those bedclothes are pulled tight, then that's going to increase the pressure between the bone and the bed. Therefore, it's going to increase the compression of the muscle. Therefore, it's going to increase the compression of the veins. Therefore, it's going to cause venous stasis. So sometimes take the weight off. Anti-embolic stockings, tight stockings that go all the way over the calf muscle, or indeed sometimes up the full length of the leg. These are used routinely now here pre-operatively. And what these stockings do is they evenly increase the pressure on the muscles of the leg. Therefore, they increase venous return and prevent venous pooling. So tight anti-embolic stockings used really quite routinely now. Another thing that might be done, might be medically prescribed, is subcutaneous heparin for patients that are at particular risk from DVT. For example, pre-operative patients, because DVT can be a particular problem post-operatively. They might be prescribed subcutaneous heparin. Normally 5,000 units, maybe twice a day, given subcutaneously into the abdomen. Not a full anticoagulation dose, but enough to stop the blood from clotting, hopefully, abnormally in the legs. So anti-embolic stockings and prophylactic subcutaneous heparin. Anti-embolic stockings, prophylactic subcutaneous heparin. 5,000 units, probably twice a day. So, leg exercises, active and passive. Don't lie with the legs crossed. Don't lie with a pillow under the calves. Encourage deep breathing. Regular changes of position. Use a bed cradle to take the weight of the bedclothes off. Use of anti-embolic stockings and possibly prophylactic heparin. The prevention of deep venous thrombosis. Now emboli, an embolus is anything which is on the move through a blood vessel. And we've already said that as a result of a deep venous thrombosis, blood clots can come back to the right side of the heart, and from the right ventricle they'll be ejected out of the pulmonary artery. And the pulmonary artery quickly divides into two other arteries, the right and left pulmonary artery. And very soon these start to subdivide very quickly into the many arteries which supply the lungs with blood. So it breaks down very quickly into the arterial tree. And you can see clearly here that the further we go away from the heart, the smaller the blood vessels become. So if a blood clot on the move, an embolism from the lungs is, say, from the deep veins of the leg is, say, that size, it'll pass through here okay, maybe it'll come up here, pass through that okay, pass through that okay. But then when it gets to this smaller vessel, it's going to get stuck, it's going to occlude it. And that, of course, means that the part of the lung tissue normally supplied by this arterial vessel will be deprived of its blood supply. And that blood will not be able to become oxygenated, and that will become blocked off. Now, if there's enough of these pulmonary emboli, or if there's a great big one, say a great big one that blocks off this vessel here or blocks off here, there's a very large one like that, a very large emboli from a DVT breaks off, then that's going to kill your patient straight away. This is a cause of sudden death. So it depends on the size of the occlusion. Small emboli can cause many small areas to be deprived of blood supply. Large emboli can cause very acute, life-threatening conditions. So that's what happens in a pulmonary emboli. In pulmonary embolism, parts of the lungs are cut off from their blood supply. So a PE, we normally abbreviate this to PE, may occur following a deep venous thrombosis. So we very often talk about PE secondary to DVTs. So if the thrombus in the calf, or whatever leg vein it's in fact, passes through the venous circulation, the right side of the heart, and then becomes lodged in the vessels of the pulmonary circulation, we have a pulmonary embolism. So when a thrombus becomes detached from the vessel wall, it moves freely through the circulation until it becomes lodged in a smaller vessel, and then it's called an embolus. So, if you like, an embolus is a clot on the move, a thrombosis is a clot where it was first generated. Now, there are other causes of pulmonary embolism other than DVT, of course, but we're going to limit ourselves to this one at the moment because this is the one that normally occurs as a complication of immobility. What we're going to look at now are some scans supplied to me by Dr. Keyes in medical physics. And what they do there is two things. The first is they inject an isotope into the circulatory system to show up the perfusion of the lungs. So you can see the blood supply through the lungs. And the second thing they do is they inhale a radioactive labelled isotope that shows the ventilation of the lungs. Because if you think about it, initially, if there's a pulmonary emboli, that's going to occlude part of the circulatory system, but it's not going to stop the air getting in and out, so the ventilation would look normal. And these are called VQ scans. V is the physiological shorthand for the ventilation, the air going in and out of the lungs, and Q is the physiological abbreviation for the perfusion of the lungs. So we talk about VQ scans. And initially, in an acute pulmonary emboli, there would be a VQ mismatch because V would be normal, ventilation would remain normal to begin with, and Q, the circulation, would be abnormal because part of the circulatory system is occluded by the pulmonary embolism. So let's have a look at these pictures now. And the first one we're going to look at is a normal perfusion. What we're looking at here are the lungs, the perfusion of the lungs highlighted with a radioactive label. So what we're actually looking at there is the blood, in essence, in the lungs. From the back, from the front, and you can see that's looking left oblique and right oblique. You can actually see the three-dimensional pictures of the lungs there actually quite clearly. And this is normal. All of the lung fields in the four different views there being well perfused with blood. Now the next shot we're going to look at is an abnormal one where there's multiple pulmonary emboli. And in this case, instead of having full lung fields like we have here, then part of the circulation to the lungs is cut off by multiple pulmonary emboli, and we'll see the difference between the two. And here we have the same four views, but this time in a patient who's got pulmonary emboli. And I think straight away you can see the differences. you can see that this area here, for example, is not perfused with blood. This area here is not. This area here is not. This dark area here is not. Of course, this is where the heart is here, so that's probably normal. You can see the difference in intensity in the different parts of the lungs. So an abnormal perfusion, because part of the vasculature is occluded by emboli. And if we just cut back to the normal, just to see the difference again. So back to the normally perfused lungs. Then to compare it one more time to the abnormal. And I think you can see the differences there fairly clearly. Now here's the ventilation scan of the patient with the abnormal perfusion scan we've just looked at. And this is actually normal. Both lung fields are normally inflated here. And this is because the pathology is affecting the vascular system and the bronchial passages are still open. Now in time actually they will deteriorate, but in the acute condition the ventilation remains normal, the perfusion is abnormal. But of course, as the air goes to the areas where there's no perfusion, it will not be able to give its oxygen into the blood. It will not be able to give up, to take out the carbon dioxide. Let's think now about the clinical picture seen in PE. Well, very often there's chest pain, and there may be tachycardia as the pulse rate increases to try and cope with the increased pressure in the pulmonary system. And there may be rapid breathing as well, tachypnoea. Rapid heartbeat, rapid breathing. Dyspnea may occur, difficulty in breathing. I think that's fairly obvious. Why? Because the patient's not getting enough oxygen into their blood. Because the blood is not getting near the alveoli where the oxygen is. Cough may occur, and there may be hemoptysis, coughing up of blood. Hemoptysis means coughing up of blood. There may be distension of the neck veins, because if the blood is not being pumped, if the distension of the neck veins, because the systemic circulation might not be able to drain properly back into the right atria, because the right ventricle is unable to empty itself properly because of the occlusion in the pulmonary circulation. So there may be distension of neck veins. There can be shock and sudden death in more severe cases. So let's get on to the key point now. How do we prevent this? Well, in immobility, we prevent pulmonary emboli by preventing DVTs. So we need to prevent DVTs, and if DVTs do occur, detect them and treat them very early with normally heparin. We anticoagulate them straight away if DVTs do occur. Intravenous heparin straight away. So the same prevention as we had for DVT. That's leg exercises, active or passive. Don't let patients lie with the legs crossed. Don't put pillows under the calves. Deep breathing exercises, regular changes of position, using bed cradles to remove the weight of bedclothes from the legs, use of anti-embolic stockings, and sometimes use of prophylactic heparin. Treatment should PE occur. Anticoagulation with fairly large doses of intravenous heparin, normally 5,000 units stat, followed by something like 20,000 units 12-hourly. Matched, of course, with anticoagulation times. Sometimes fibrinolytic therapy to dissolve the clots, and occasionally some surgeons will do embolectomy. But the key thing I'm trying to stress, prevent PEs by preventing DVTs. And these are major problems. Sometimes young, fit patients come into hospital, maybe for a simple surgical procedure. They can have a DVT, a PE, and they can die. It's a serious life-threatening complication. So learn the preventative measures we've described and put them into practice in all of your patients.